Hi, good morning. Some some I see. Hold on, some minutes. Technical hiccup. Need to close my YouTube. Now we are talking. Okay. Yeah. Too many windows. Hello, good morning. So, welcome to our live stream. My name is Dr. Kay-Geert Hermann. I'm a radiologist from Berlin, and I'm here today to show you some new cases that we have collected in our BerlinCaseViewer database, and we also have our assistant with us today. And assistant is Asif. So Asif, let's check if you can unmute yourself just as a technical test.
Sure. Can you hear me?
It's not working. So that was what we did behind the scenes. So we tried to get the voice of both of us live, and we also have our first commenter here. This is Imran. And Imran is a radiologist from the UK, and he's watching on YouTube. So hello. And we will give him a bit later the chance to say hello and to join the studio, hopefully with sound, but we still don't know. So if you are live on LinkedIn or live on YouTube, you can comment on this platform, and we will see the comments and we can react. So what we have planned today is to let you work with us on some exciting cases. We have prepared some cases. I will show you what we have. So we have these cases provided. This is the code to access the cases. We will talk about how to access the cases later. So we have some URL prepared to what you can type to enter the cases, and we also have a QR code. Before we do that, we will show you how to access the platform, so you know what you can see, and I will explain what can be done. So I'm starting a new browser. So hold on 1 second. Exactly. Okay. So what you can expect when you get the link from us. So I will show you this one as well. It's a bit difficult to stop sharing and present the next one. Okay, so here we have this nice screen. So okay, so this is how it works. So this is the welcome screen, and you will get the URL right now. So this is the URL to what you can enter. You also get this in the comments. So we will send out the link, and we also have a QR code that is that you can scan with your mobile device. So you can watch the stream on the PC, you can look at the cases on your mobile device, or you can do both on the mobile device, because everything works on the phones and tablets as well. And I will explain how to access the cases. And if you don't want to do that, that's okay, because you can also watch, and we will explain what you can have. So we will post the comment that you can see, so you can also click on it. So if you see this comment now on YouTube or LinkedIn, I guess you can click on it so you can access the platform, and you should see exactly the screen that I'm presenting here. Okay, so what's it about? So when you go in, you type in your name and your email. You don't do that because we want to send you emails afterwards, because we have a function that is called pin and comment. And you, of course, if you comment, you need to also get a response, and you get a response to this email. So you enter your name and your email, and then you click join now. So if you do that, that would be really awesome. And meanwhile, I show you how it works after you've logged in. If you are already registered with BerlinCaseViewer, that means if you have during the last 4 years taken part in one of the BerlinCaseViewer events, which are mostly free events because they are sponsored by other companies, and some are also for a fee. So you have already an account. So that means if you enter your email address, you will get an email with a link that you click that will bring you directly to the cases, and you will also be able to enter a code if you are working on a different device. So it will all work out, and I will go in and see what is or who's already there. So we have one so far one guy did try it. So okay, so we need to check how this will work. So we have this URL and the QR code, and please try it. So I will now go on, and if you have any questions, please type them in the comments, and Asif will try to help you, and maybe you also WhatsApp back and forth. We have in WhatsApp helpline that I prepared, so you can take a screenshot of this number, which is our backup support channel, and this will help you. Get in touch with us in terms of when something is not clear, and also when after the show you can still ask questions with this code. Okay, so let's do it. I'm trying it here. So I'm going offline for some seconds to prepare, and then we will continue with the cases. And we have really 3 interesting cases, so give me some time to prepare. And we are back. Okay, so now I'm sharing my screen, and I will do this with this one. Okay, so this is our platform for today. These are the cases. So after you're logged in, you see this button with 3 cases, live stream. And we have prepared 3 cases, and I think we start right now doing the first case, maybe have a break for you to give some feedback after the first case, and then we go to the second case. And then we also have some announcements that we will do between the second and the third case. Okay, so let's start with the first case. So this is a 60-year-old man who is a farmer in a remote rural region. This case was provided to me by a radiologist from the Middle East. So the patient had needed some time to go to the doctor. Basically, he was getting stiff over the years, and his wife said, now it's time to see the doctor because he could not walk normal. And the family doctor already did some did some X-rays, and the patient attended the clinic, but forgot to bring the X-ray. So we only have the MRI that was done. And also there's some lab tests already available. That was B27 that was done. It was positive, and CRP was slightly above normal, so 5.5. And the patient was had a BMI of about 26. So in all of our cases today, we have the BMI. I think it is important to know about the weight and the height of the patient, as it is sometimes very informative to get the differential diagnosis, etc. Okay, so that's the history. I see that now the one or two did enter the CASE platform. So the idea is that you take a chance to look at the cases yourself. So what you can do is you can scroll through the cases. We have this slider bar over here, but I think it's also easy to click on the image and drag up and down to advance the slices. You can also do it on your mobile device with your finger. And then what you do is you first analyze which type of sequences are shown. You see there's no values here, no names of the sequences. So you need to find out based on the images what it is. And that is usually done before you enter, you switch on your brain to see what you can diagnose on the images. So I would recommend you're doing it, and then after some time, I'm looking always here to the side to see how active you are. So I have a feedback device here, feedback monitor, where I see how many did access the case and how the series are viewing. So that is not personalized. It is just statistics. So I know when to finish and when to go to the next case. Okay, so what we have here are 4 sequences, and after this 4th sequence, you should answer these questions in order to see the next sequences. Here in this case, you already see it because I have a different view to the case than you have. So you have to answer the question whether right or not, and then you can see the next images. Okay, so here we have the first one, and this, before we look at the sacroiliac joints, we should try to find out if it's a T1, T2, or STIR, or after gadolinium. So you should always check the subcutaneous fat. If there is some, let's do this one. I think it's better, and yeah, do it like this. I think it's better like this. And we have this one. So subcutaneous fat is bright, disc is dark, and that is clearly a sign for a T1 weighted scan. So if the fluid is of low signal intensity, it's always a T1. And then the fat is bright on a T1. And that's the key. Then we have another sequence here, which is rather dark. So we need to scroll to see the disc. The disc is now bright and the fat is extremely dark. So this is when the disc is bright, the fluid is bright, it's always a T2. You see the fluid also here in the veins between the muscles. So fluid can be found in many places. So we have this high fluid signal intensity, low signal intensity of the fat. So that is a fat saturated T2. So it's not a T2 classic, it's a fat saturated T2. So it's already adjusted for our purpose in rheumatology imaging, where we want to see active inflammation. Then the next sequence, this is a bit special sequence. We see the signal intensity of the disc is a bit intermediate. We have rather high signal of the cartilage in the joint. If you compare it with the T1, we see there is the joint to be seen here. It is rather narrow, the joint. Also here it looks like it's bright. And here on the STIR sequence, we cannot see the joint space very well. We see a little bit of faint bright signal in the joint. So the cartilage shows up much brighter on this sequence. And this is a proton density weighted gradient echo spoiled sequence with fat saturation. So that is a sequence that can be used to search for erosions and to analyze the contours of the joint. And then the fourth sequence is a sequence that is nowadays only rarely done. You see the fat is dark, so it's a fat saturated sequence, but we have bright, we have a very dark appearance of the nucleus pulposus. So it's a T1 weighted sequence. And this T1 weighted sequence usually has bright fat, but here we have fat saturation applied, so it's a fat saturated T1. And these sequences usually are combined with gadolinium injection. So if you look at the vessels, they are filled with gadolinium, they are bright. Also here, the large vessels are bright. So we would expect inflammatory activity showing up bright in this sequence. So what can we see? The diagnosis was asked. So what is the diagnosis? I gave 4 differentials. Is it TB with ankylosis? Because clearly the finding is ankylosis, but that's not the diagnosis. You need to take the finding and make the diagnosis. So we have ankylosis of the joint. We see there is fusing of the bones. We have the residual joint space here, which is sometimes called a phantom joint. We have a little bit of bone bridges here, and then we have a lot of fat tissue surrounding the joint. So these are called fat lesions or fat metaplasia, and these are usually occurring after long-standing ankylosis and long-standing inflammation. We know that the hematopoietic marrow that we see here in the center of the sacral bone is changing over lifetime, and the amount of hematopoietic marrow is decreasing with age. So we need to distinguish these changes from age-related changes, but these are very bright and also clearly have a clear margin to the hematopoietic red marrow. So we would not see this as age-related fat changes, but these are disease-related and are called fat lesions or fat metaplasia. So we have ankylosis and fat lesions, and here we can decide, is it TB with ankylosis? So TB makes ankylosis in the end stage, and also the septic arthritis is healing out with ankylosis, and we know this from the spine, we know this from peripheral joints like the hip, and also the sacral joints. They can be fused, but this is a bilateral ankylosis, so this would be very unusual for a septic condition or bacterial sacroiliitis or TB sacroiliitis to have both joints affected in a similar manner. So it's very unlikely. So diffuse idiopathic skeletal hyperostosis DISH would not do ankylosis in the joint. It would lead to ankylosis of the joint capsules, maybe of the anterior aspects of the joint. Then axial spondyloarthritis with ankylosis, I think this is the correct diagnosis. And then I also needed to find a fourth differential, and I came with the motor vehicle accident because sometimes if you have a disruption of the joint, if it is a torn joint, a destroyed joint, sometimes it heals with ankylosis. It's rare, but of course it never occurs on both sides. So let's see what were the results. So I have one friendly colleague who is taking part. So thank you for giving the right answer. Okay, so now we have the lumbar spine imaged. And you see this is a wealth of different sequences. There are 6 sequences covering the lumbar spine. And we can learn a lot when looking at it. And at the end, there's even a question about it. So you should take a careful look. And also, I would like to stress that it's really useful to go on and engage with the cases. Even you can take a note of this URL, as it will stay active for the next maybe 6 to 12 months. So you can always go back and look at these cases. So try it, because I would like to know how much you know in order to learn on how much of detail I would need to explain. So do we have any new comments so far? No. Okay, do we see how many people are on this live stream here? I don't see it. Yeah, 5 people, I see it. 5, nice, very nice. Okay, so let's continue. We have here the spine. So we have the different sequences. So let's check. So here's the first one. I think it's easy because I already explained at the sacroiliac joints what you have to do in order to find out which sequence is there. We have dark fluid, we have intermediate to dark nucleus pulposus, and we have bright fat. So this is a T1. So now the next one, and I compare it so you can easily see it. The next one has bright fluid. The nucleus pulposus is a bit brighter, and my friend said I should explain as much as possible. Thank you. Your feedback is valuable, and also in the last live stream you were very friendly to me. So I will do as much as I can. Okay, so we have the T2, which is bright fluid, but the T2, the regular T2, has also bright fat. So this is very important, and usually students mix it up and think that T2 is the opposite of T1, because in most of the times, T2 fat set is shown, and in T2 fat set, indeed, fluid shows up bright and fat is dark. So this would be the opposite of T1, a T2 fat set. And but here it's a conventional T2, and there the fat is bright. So this is a very important point. Then we have the third sequence, which I think is a stir sequence or some kind of stir sequence. As you see that there's a lot of image grain. There's some fluid here in the soft tissues. Fluid is bright, nucleus pulposus is bright. So we have the stir sequence, and we have the next one, which is a T2 fat saturated sequence. So somehow I would do only one of the two. They give the same information. You can see that the signal that you get is much more homogeneous on a T2 fat set. So if you make it similar brightness, so you see there is very clear bone marrow here. We see the residual disc here. We see the vein in the first sacral segment, and here in the stir, we can faintly see this vein and also this disc, but there's a lot more of image noise here. But this has advantages because stir is usually a stable sequence, very robust, and can be done with also low field strength magnets. And you see also here there is some motion artifacts from the bowels overlapping the vertebral bodies. That is somehow not here, but I've seen a lot of stirs also with these artifacts. So you have to decide on your local, based on your local circumstances, if you do a T2 fat set or a stir. If you're a rheumatologist joining, you can only memorize that both are actually the same in terms of how the lesions look like. So that is no point. And then we have this fifth sequence, which I'm not quite clear what there is a difference. I think this one is a classical T1, and this might be a T1 Dixon, but I'm not sure. It looks more or less the same. There is some difference in the signal intensity of the myelin. So this might be a Dixon. I could check it up, but I won't do it now. And then we have the sixth sequence, and the sixth sequence again, and I'm asking you, what do you think is the sixth sequence? If you would like to comment it, so that sequence that is shown here, which sequence is it? Yeah, about the bowel, Imran, the bowel, so sometimes you see it, sometimes not. I know there are some, if I would be an MRI technician or MRI physicist, I would maybe know more how to adjust the machine to avoid those artifacts. T1 post-contrast, yes. T1 post-contrast, very nice. So you see, it's dark fluid, it's dark nucleus pulposus, and it's dark fat. So it's all black. Everything is black. So we need gadolinium in order to see if there's inflammation. So we see these bright dots over here. These are the basivertebral veins. So these are venous. This is a big vein draining out all the blood from the vertebral body into the paraspinal, into the plexus in the spinal canal. So we see there is gadolinium here. We have also some gadolinium in the urine bladder. We see some gadolinium uptake here, and we also see maybe a bit of inflammation here in the posterior aspect of the vertebral body. Okay, so when we compare the T1 with the T1 fat set, then we see that these areas here, these lesions, they are bright on T1 and they are dark or black on T1 fat set. And why is that? Because yes, we saturated the fat, so we made it black. So this already we can assume that this is fat. We would need on T1, all that we see bright is fat. Could also be gadolinium and some other rare situations where we have signal showing bright on T1. I think melanin is also one of the substances. But I'm not sure. But this is fat, and we did fat saturation applied, so we made it dark. We can look at it here on the T2. We see fat bright, it's bright. So of course, if we only have a T2, we cannot distinguish between fat and inflammatory lesions, because there is an inflammatory lesion in this patient. I'm not sure who found it already. And then when we go to the T2 fat saturated sequence, we see the dark areas here. Because fat is now saturated, it's also dark here. There's a little bit of bright signal over here, very faint. But there is one clear. So check the images and name the location with an active inflammatory lesion, so not fat, please, that is clearly visible. So please take some time and look which of the sequences is clearly visible. I would be really pleased to know what you find out. And I'm waiting. I'm waiting for the answers. And please use the chat and you use the voting feature in our platform. So what do we have? So this is the second question. One guided answer. Here we had two people answering, so I would wait for the second one. And here we have the facet joint. Yes, wonderful. The facet joint. You're so good. You're so good. Okay, let's do it. The facet joint. I'm not sure who found it because I tried not to show it on the video stream. So here we see in the central slices, there is no inflammation. It's all dark, and we see some of the artifacts here. There. But if you go to the lateral slices, this is the region where we see the facet joint of the lumbar spine. And here on this side, we see showing up some bright signal in the pedicle of the facet joint. So we see the facet joint between the fourth and the fifth vertebral body. Lumbar vertebral body. Here see it even better, even on more sides. And when I now go to the T1 fat saturated sequence, I see it clearly. So you see here, you can see the surrounding soft tissue inflammation. You see a bit of bone edema here. And we see some bone edema here. We see some soft tissue, so capsular inflammation of the facet joint. And here we see the bone edema in the pedicle, also the capsular inflammation. So that is, I think, the largest inflammatory lesion in this patient. There is also this posterior spondylitis lesion, but I think it's too small to really make significant pain. And then there's also this small lesion over here, which is close to the do you see here? We have bright signals. So these are sequelae of older inflammation, but this one corner is dark, and here it shows up after gadolinium. So this is some example where we could see that because in the stir somehow this joint is not really good showing up. So this is some. I usually won't say a stir is enough, but here we can see that the stir did not detect the facet joint. T2 FATSET did, and the gadolinium sequence is just beautiful to show the change. So this is something that is not so frequently found. It's an incidental finding. So we have some questions. Often enough, you see fatty or healed of active Romanus lesions in degenerative spine. Are they also called Romanus lesion, or you must use different nomenclature? Okay, so in fact, the dilemma is about the term of Romanus lesion. So what Romanus did do, give me some second. I recently gave a talk in Montreal, and we spoke about Dr. Romanus, and this was really very insightful. So this gentleman, Dr. Romanus, he was, of course, in his full capacity to study the disease, and he of course did all his publications in the 50s. So he wrote a paper in 52 and wrote a book in 50. Put this away. Can do it like this. Yes. So this is his book, and it was published in 55. And my colleague Thorsten, I don't know if he's on the show today, has this book as an original. And these two gentlemen, Dr. Romanus and Dr. Eden, they wrote about pelvis spondylitis ossificans, and especially focusing to its early diagnosis. So what do they mean with early diagnosis? So they mean spondylitis. So they made errors in their book, and these lesions are so tiny. Today, our residents would not dare to magnify those vertebral bodies to search for some early erosions. But this is what Romanus did describe. The Romanus lesion is an erosion at the vertebral corner that you can also see here. That's a Romanus lesion. And that is also what he did describe was the sclerosis next to it, which is now called as shiny corner. And he wrote in the book shining corner. It's a shining corner in his book. So that is what Romanus described. So I would, and also the expert in the others group would recommend not to call lesions on an MRI scan Romanus lesions, whether they are active or fatty. I know I was one of the authors like 15 years ago who introduced the term of Romanus lesions for the spinal MRI, but I think we were wrong doing it, and later on we corrected ourselves. So I would say it's a fatty lesion on the spine, and the question was how many do you need? The question was how many do you need, and how do you call it? So we call it fat corner lesions or fatty corner lesions or healed spondylitis lesions. So that are the possible terms. And the amount of these lesions was decided to be 6 or more in a paper from 2012. So meanwhile, we have better data based on the MRI imaging project of the others group, but I'm not aware how many are now required. So 6 fatty lesions are sufficient for the diagnosis of axial spondyloarthritis or suggestive of the lesion. And for the active lesions with edema, 3 of them are suggestive of axial spondyloarthritis. But with fat changes, you see it also in degenerative changes, as you have here very nicely said. Okay, I will go further with the case and will start with the case presentation again. So this is the case again. So we have this facet joint and we have these fat lesions here. And I think we discussed them all now. Here we have the spines, the spine images. I think we go, we skip them. I think I also see that we spend a lot of time going through just this one case. So here we see also the costovertebral joints. They have high signal intensity. This is a D1 weighted. The fluid is dark. We see this is maybe due to fat. And if we go to the T1 here, we see there is a lot of fat in the posterior aspect of the vertebral body, same as in the anterior aspect. So this is a fatty arthritis of the costovertebral joint. So fat already means it is healed out, and we do not know about the active changes. So I think that is a good point to go back to our cases, and I will now do. Okay, I copy that one, and we'll see how I can do it. I will, so Imran, I'm sending you now the link to join, and this is here. So try it. So if you try that link, and if somebody else would like to come to our show and show up and say hello, that is possible. I can send you a link to join. If you send me a WhatsApp, that would be nice. So then I can send back the yeah. Where's mine? I lost my. I have too many windows open. Sorry. So we have, yeah, that's the WhatsApp number. So there you can send your request to join, and we will wait for Imran from UK to say about how he found the session and what he's doing in terms of education and musculoskeletal radiology. So meanwhile, I can also tell you about what we are doing. So we have two different things in the planning. We have the BCV expert talks coming. The first one will be on October 10th. And we have the BCV Online Academy coming that will start mostly at the same date. So it's some days until we start that. The BCV expert talks is something very fun that I will show shortly on the screen. Meanwhile, we will see how Imran is doing and if it is somehow working with him to join. Not working. Okay. The link is not working. Let's try that again. Invite. The link is not working. Copy. So Imran, if you like, so everybody who likes can join. So if I'm sending this link to the chat, so if you would like to join, you can do, and we will for full control whether you put you on stage or not. Meanwhile, I'm showing you the yeah, we have Imran here. Very nice. Very, very nice. Hey, he's there.
Hey, how you guys doing?
But no sound. I don't know what's going on.
Okay.
I don't know. I don't know. We have to test this. I also previously with Asif, I was impossible to start the sound, and I'm not sure how I can solve it. Even. Yeah, it's very pity. So you see now, if Dr. Imran Lasker is known for his fun TikToks and YouTube videos, and also does serious videos about musculoskeletal topics, but also other fields of radiology. and he is also running a community called Radiology Seminars. That is a quite new service. He started in May, and there people are joining to get advice on their cases, and there's regular case reviews, etc. So that is something he did ask me to join as well, and it's really very interesting. And you see, he's not someone who stays behind buying new tech stuff. So he has everything, but somehow I think it's the platform that is making us trouble. So
really, can you not hear
me? It was
me?
nice seeing you, but we need to check this out later on, because in our experts talks it is the same. We will have discussions with our fellow radiologists. So I will share my screen to show you about the planning of our BCV expert talks. So what we have is that one. Yeah, that's the BCV expert talks page. So this is our landing page that will go online next week. So we have this series of events. So these are in fact 12 events that we have put together. Each event is accredited with 3 CME points by the Berlin Medical Association, and I think these points are also convertible to CME points in other countries. I will moderate those talks, and these are our speakers. So we have tried to be very diverse and have speakers from all parts of the world, and we have exactly 6 women and 6 men. And they are all experts in their field of musculoskeletal radiology. And I'm very much looking forward to speaking with these friends. Most of them I have met over Instagram and LinkedIn, and some of them I have met in person. And here you see the lineup, the topics. You see it starts on October 10th. You even can convert it to your own time zone. So if you click on this My Time Zone link, you will see it popping up in your browser, in your time zone. So of course, if I do it, I will see it in my own time zone, which is the same as it listed here. But you will see then in your language and in your time zone. And each of the events costs 59 euros to attend. And if you attend 3 or more events, then we will adjust the price, and it will be only 49. So that means if you let's say you will take part in the second one, then you have 59 euros, and if you join more, like 3, then you have only 49. So it's automatically adjusted, and that is, and also I wanted to tell you that if you want to book all of them, you can do it, but please wait because we have an online academy starting. So it is an educational academy, and we have 3 membership tiers here. We have the free membership, where we include everything that we have currently on the BerlinCaseViewer app as a free service. So in the BerlinCaseViewer, as you know, the BerlinCaseViewer showing up here, I think that one is good. So BerlinCaseViewer has a lot of free stuff in, and all the free stuff from the BerlinCaseViewer is now showing up in the free academy as well. But we have more in these academies, because we also have lectures that the BerlinCaseViewer app has no lectures. So we have here some lectures that we collected over the time. We have the educational plan, which is suited for students with some chest X-ray courses. That is just 10 euros a month if you pay for the year, or 12 euros per month if you pay per month. And then the full plan is the full package with lectures by rheumatologists, a lot of cases, and we will expand this library over the time. So that is the plan. So I see that I somehow I'm always the same lazy, or not lazy. I'm not lazy. I'm the opposite of lazy. I'm talking too much. So I spend 1 hour almost to bring you this one case, and I could not, however, show you the second and the third case. But surely this is really interesting, and I'm not holding behind. So we have this case number 2. Which is a saleswoman with 4 children, and invite you to look at it. It's really a nice case with MRI, also with CT, and I think it's obvious for those who are in the field what the diagnosis is, but I won't reveal the diagnosis here. And then we have this gentleman, or this woman. She's having some discomfort after longer walks. MRI was performed, and also a CT, and CT brings the diagnosis here. MRI is really a bit difficult to understand. And this is also something that I will not go through now, but you have the link, you can do it. And later on, I will make videos about these cases, but I will not make this session longer than planned and not longer than 45 minutes, and it's now already 50 minutes. So do you have any questions or comments that you would like to ask? Okay, that's interesting. Imran could be heard by all of you except me. So that is an interesting learning for me. So I need to improve my skills here with the live stream. It's the second live stream I'm doing. The last one I did in May, and somehow I will learn this game. Okay, so anything you want to let me know, please do it. We have a lot of fun doing it. We will not stop bringing education to the internet on our platform, but also on platforms like Instagram, YouTube, or LinkedIn. I invite you to check out our BCV talks that will come up next week, and also the BCV Academy that we will also launch late next week or early in let's say 10 days or so, because we are now polishing our landing pages and making everything neat and clean. And if you want to ask us anything, you can use this WhatsApp number. You can do it related to our apps, related to cases, and just save this number on your device, and we can advise on what to do with our services. And I will definitely do the other videos again. I have the tendency to speak too long, so I will need to somehow make it shorter. Okay, thank you, everybody. It was very entertaining for me here on this Sunday morning. I even have prepared my sacroiliitis mark. I didn't need it in order to explain what's going on, but this is certainly something that is fun. It is available in our shop, different types of arthritis marks for learning, if you want to do that. Okay, thank you very much, and thank you for joining, and it was fun to do it. Bye-bye.